and of some long-standing, I am interested in immune therapy for many things, especially in the case where there's something wrong with the brain. But that doesn't work out a lot, but in Holland we have much more interest now in toxoplasmosis and inflammations of the brain and so on. And there's even a professor now in Rotterdam, who is especially named for that thing. What I'm going to present is just what a little bit angry psychiatrist does with a few cancer patients, because when I visited a few oncologists and a few immunologists in Holland, they were not very much interested. That was 6 years ago. So after a few years, when I stopped my practice, normal practice, I still did the practice of psychiatry and acupuncture. I started treating cancer patients with Gcmaf treatment. And here you see my patients for the first 2.5 years. I'll just name the patients very fast, and then I'll show you a few graphs that show the results in a better perspective. And afterwards we can have a little bit discussion about what I found in this very small sample in between my psychiatric practice. The patients are in the order of the laboratory ELN in Bunnik that we did the Nagelhaas tests with. So you can also say I treated Nagelhaas elevations in a way, but the patients went to see me too. Mm-hmm. Oh, well. Oh, it's better.
Can you increase this?
Oh, well, it is on the website too.
F11, we call it page. It's on 4th page, F11.
One of my first patients was a female, a woman 47, with treated breast cancer, but still having complaints. And you see here malaise, fatigue, and sleep disorder. And her Nagelhaas was on August 11, 1.70. She was treated with Gcmaf, intramuscular. She did it herself. After a few times, I did it intravenously because it was one of my first patients, and we were not sure that we were sure from the literature that it would have some advantages because it works faster. Well, now she is having had Nagelhaas testing of in March 12 of 72, 0.72, and on December 0.60, and she's very well, and she comes perhaps once each half year or whatever she wants. The second patient is a male born in 50, carcinoma of the urine bladder, who was treated locally, and his Nagelhaas was 3.10 on July 2011, and now it is not 1.40, but it was in February, it was 1.0, so he is not yet safe, but the urologist considers him treated and cured. The last one is not named here, I forgot to put it in. It is from 21 February, it was 1.0, but it will be changed on the website. The third patient was a female of 50. She had very specific complaints of metastatic sites, and she was locally operated, irradiated of the thorax combined with chemotherapy, and she had also had this immune therapy, Herceptin, not with much results, and she had many complaints about the treatments too. The Nagelhaas tested in May 11 11, 5.60, and nowadays she is under 1. She tested on 8 February this year, 0.95. And she is treated originally with intramuscular and later intravenously. She is a wife of a colleague, a homeopathic colleague, and he learned from the family doctor how to use an intravenous needle. So very good. And she doesn't have any complaints anymore, and I understand she's now having a nice stay in India with her husband for homeopathic courses or so. Another patient was an acquaintance of me, was hepatitis C seropositive, with only slight liver functions, and because the patient's HIV were treated well and cured by Yamamoto, I proposed her to treat her with Gcmaf, what I provided, and she was well interested. And as you can see, the Nagalasa is going down every test, but on 15 June 12, the Nagalasa was up from 1.10 to 1.90. What happened? She discontinued the treatments to get herself intramuscular for 4 or 5 weeks. And you see, it bounces up, and it's perhaps because it's a live virus that infects new, not infected cells. And after that, when the treatment was continued, the Nagalasa now is 1.10. On 20 December of 12, but the testing is not yet back from the laboratory, but that was 1 month ago. There's also something with vitamin D, what is low. Perhaps someone can tell me whether when someone is infected with hepatitis C, that does something on the B12 function. I don't know. The experts didn't say anything. Another patient is a male born in 37 with prostate carcinoma found by PSA testing in 2009. He had no specific complaints, but he was operated on colon carcinoma in the same year. And we don't know, but probably and cured. But his Nagalasa was 2.0 on April 11, and now it is already in July 12 and December 12, 67 and 75 after a point. So I consider him cured. And he is an acquaintance of me, so I see him and he's very well now. He's working still as a psychologist. Well, these are a few patients I told you, but now we can perhaps get better to the second where I have some graphs of 4 selected patients. These graphs I made with the help of Gcmaf. These are the graphs Yamamoto published in 2008, and the left one is colorectal cancer. The Nagalasa is on the vertical, and the time of treatment is on the horizontal. You see the number of weeks on the right. And the second one is prostate cancer, and the third one is breast cancer. As you can see, the time from Nagalasa to normal, it takes the longest in the colorectal cancer and the shortest in the prostate cancer. Perhaps that has to do something with the number of cancer cells or with the diagnosis on itself, I don't know. But also my patients were investigated with this kind of graph, and I'll show you now my patients. On the right side, And these are 2 bladder cancers and 2 breast cancers. The upper one is a breast cancer case. That is the case of the female that was one of the breast patients at start. And the lowest is the breast cancer patient that was nearly the best, one of my first patients I told you about. And the 2 in between are cancer of the bladder, the urine bladder patients. And one of them was very good reacting, and the other one had a lot of problems, but now he is considered cured by the urologist, but stays under control. If you project these results of mine over the longest from Yamamoto, you can see this, that Nagalase takes somewhat longer to become normal in my patients than in patients of Yamamoto. And that can have very much reasons, like pharmaceutical, chemical, the TC globulin that's used, can be anything. But there's one thing today that comes to that, that is perhaps we used vitamin D3, what was advised in all my patients. In all my patients, the vitamin D3 was low, too low, and it was suppleted. Well, perhaps 1 or 2 of the patients didn't do exactly what I advised, but most of them did it, and 1 or 2 patients took more than 8 weeks to get the normal vitamin D. Just taking those drops 2 times 7 drops a week to get it to 3,000 to 4,000 units a day. That was advised. Well, then we have the summary. I told you nearly all I can tell. In the summary, there are a few other things I'm telling, but that is just because there are other possibilities that it took longer in my patients than in Yamamoto's patients. And I'm not sure whether it's the vitamin D can be the product, can be anything. But my patients had the same kind of battling and lowering of their complaints like Yamamoto described. That's what I want to say. You can read it. Oh, well, David advised already, well, more than a year ago, if there's trouble with patients, you can use, of course, DCA in fast-growing tumors, but also you can double the dose, or double the frequency. Well, I'm a little bit homeopathic interested, so I doubled the frequency and not the dose in few patients, in few instances. In the 2 instances I did not see a spurt in the Nagalase lowering. That I can't say. It just went the same way, but went the good way in my patients. Thank you. But perhaps there are some questions. These patients of mine were not psychiatric patients, they were just patients with cancer. 2 or 3 of them had also sleeping problems, depression, anxiety, of course. But in the normal battering of the symptoms, that went along. But I can't say that after 1 or 2 injections it did something to the psychiatric problems. I don't think. In the first weeks they changed a lot, but also they had, of course, kind of trust that the treatment was working because the pain and other symptoms vanished. You know, and that can do a lot to the patient if he has anxiety and depression before. But they were not treated with psychiatric medication. None of the patients, also not by that. Well, perhaps 1 or 2 had tablets for sleeping or something, but I stopped that quite fast. But I'm now trying to do Nagalase testing on psychiatric patients. And I can tell, but it's perhaps not for all too interesting, that we have 2 patients with amyotrophic lateral sclerosis where there was a level of Nagalase that was too high. well, one of them died, and the other patient was treated by a colleague of mine, but he did Nagalase testing, but he did a lot of treatments, and he did not start with the Gcmaf treatment yet. As far as I know, the Nagalase was in these two ALS patients too high. And in patients with schizophrenia, I have two tested, but I didn't have the Nagalase testing yet. Well, the blood was taken, but the test is not yet. And well, this Professor Hemmo Drekshagen in Rotterdam, I have contact with him, but it takes a little bit of more interest from his side to do something in that field. That's my interesting, of course. But I will take, I now have 22 or 23 patients. I will take 26, just one alphabet of cancer patients, and then I will go back to psychiatry. Yes? Thank you.
I have to make a comment. I mean, we have about 100 scientists and medical doctors invited by your company. You met me in the morning and you introduced yourself as not being a scientist. You say, David says it should be so and so. I think Yamamoto has never really established that Nagalase serum levels would correlate with clinical results. And we are in a session called Clinical Results. I respect you as my colleague, and I'm happy that you presented some of your cases. But this is not a case presentation, it's nothing. Clinical evidence starts with the lowest evidence of a best case series. And if you have promoted for 3,000 cancer patients in the last years this treatment, there should be some evidence. This is no evidence at all. If you do a staging, you have to present how many patients have been treated, what was the route of administration, what was the staging, what was the parallel treatment, and then you can really start doing a documentation. This is nothing what we hear.
Yes, of course, you're right.
Urge the company to do the homework and invite speakers, with all respect, who are able to present clinical data.
Yes, but I'm not an oncologist. I told you before, I'm going to show you a Nagalase level treatment.
This is nothing, I'm sorry.
No. I told you before, I'm going to show you a Nagalase level treatment. I'm not an oncologist, but these patients were also with their oncologist, and the urine bladder patients were the best because the urologist looked into the bladder, you know. But you're right, of course.
Thank you very much. Thank you very much indeed. I'd just like to make the point that it is incredibly difficult to get feedback. Excuse me, can I just make the point? It is incredibly difficult to get feedback. Only about 15% of our doctors and patients give us feedback, even though they contract with us. They agree to give feedback every 8 weeks, and that is the position, that is they have to agree to that to get Gcmaf. And 85% of them break their contract with us and do not provide feedback. So we are presenting what we have. We'd like to have a lot more. We would love to do fully respected professional trials, but when you go to Guernsey and ask them to do trials, they threaten to arrest you. So it's actually quite difficult to do what you ask.